Good afternoon, everyone, and thank you for joining me today for the webinar this afternoon. My name is Professor Nick Alderman. I'm consultant clinical neuropsychologist and Director of Clinical Services at Brain Injury Services. And this afternoon we're going to be talking about neurobehavioural rehabilitation and ways to reduce challenging behaviour. This is part of a series of free webinars that Partnerships in Care and Brain Injury Services are going to be hosting over the next few months, with a second session being delivered next month, which I'll talk to you more about later. Okay, so what we're going to do is talk briefly about, first of all, the context for today's talk before moving on to talking about neurobehavioural rehabilitation in particular. And I guess many of you who have logged into this session today will already be familiar with acquired brain injury and its problems, so I'm not going to talk about that in detail, just a slide with some bullet points to talk up the main issues and to provide a context for today's session. So, for example, a current estimate is there are approximately 720,000 people who are living in the UK with the long-term effects of head injury. And in addition to that, we see a further 320 to 702,000 people living with stroke-associated disability. We particularly see this in recent years with advances in medicine, meaning more people are surviving acquired brain injury, often with a normal life expectancy, but many of whom will have long-term disability. So road traffic accidents, as we know, are a major source of acquired brain injury, and now with the advent of air ambulances, which bring the emergency department really to the roadside, and increases in car safety features such as airbags, and with legislation, so the requirement to wear a seatbelt, for example, we see people surviving quite horrific accidents which previously would have resulted in death. And there's recognition really now throughout that the greatest challenge to social recovery for both people with acquired brain injury and some people with stroke and to their community reintegration is neurobehavioural disability. Neurobehavioural disability causes problems in particular with mood regulation, with behaviour, and with executive function. Okay, so that provides the context for the bulk of today's session, where we're talking about neurobehavioural rehabilitation. So this is the structure I'm proposing to follow. First of all, we're going to talk about what is it, what is neurobehavioural rehabilitation. Who gets referred to neurobehavioural services? How does it work? And what are the outcomes and the evidence base for this approach? Okay, so we're going to start off with having a brief look at what is neurobehavioural rehabilitation. Okay, so in simple terms, neurobehavioural rehabilitation attempts to alleviate the social handicap arising from neurobehavioural disability. And if we can look at this in a schema to get some idea about what's driving these sorts of problems, impairments and disabilities. Here we see three boxes. If we look at the box on the left-hand side here, we can see a list of essentially cognitive and other problems that are the product of brain injury. So issues such as executive dysfunction, problems with attention, problems with memory, problems with diminished insight and so on. These interact after brain injury with the person's pre-morbid characteristics, and these in turn interact with the environment. So when these three sets of factors are acting together, we see symptoms of neurobehavioural disability, and these can be many and varied. So an obvious symptom of neurobehavioural disability would be something like aggression, although we could have symptoms of neurobehavioural disability at the other end of the extreme, where we talk about passivity as well. I'm going to talk more about what the symptoms may be, but whatever the symptoms are, they will reduce in social handicaps. So essentially that's lowering or decreasing the person's autonomy and choice. And leading on from that, we know that neurobehavioural disability has a major impact on long-term psychosocial outcome following brain injury. So the person's capacity for independent living may decrease, their opportunities for employment may be limited, the quality of their relationships can be adversely affected. For some people, there may be an increased contact with forensic services, and the person's quality of life can deteriorate and change quite significantly, not only for the person, but for their family and for their community as well. And overall, the presence of neurobehavioural disability generally indicates a poorer prognosis. Now, these neurobehavioural disability has a long-term impact, which outcome studies have demonstrated. And in fact, the long-term outcome studies have demonstrated that without appropriate rehabilitation, there's a tendency for these problems to increase and for people to deteriorate further over the course of time. This is a difficult set of patients to provide treatment for. And it's only until relatively recently that specialist services for people with acquired brain injury have been evolved to meet their needs in terms of trying to help with neurobehavioural disability. Previously, people fell into in between acute medical services on the one hand and psychiatric services on the other. Neurobehavioural rehabilitation is quite a new approach, and just to talk about that for a moment, this was an approach that really began at St Andrew's Hospital in Northampton back in the 70s, and it was an approach that was pioneered by, in the first instance, Dr. Gavin Tennant, who at that time was the medical director at St Andrews, and two key clinicians. And those two key clinicians are Dr. Peter Eames here in the middle and Professor Roger Wood on the right-hand side. So Dr. Peter Eames being a neuropsychiatrist and Professor Roger Wood being a neuropsychologist. And these were the pioneers that really began what we now call neurobehavioural rehabilitation. Back in the 70s at St Andrew's Hospital, a number of units, specialist units, evolved, which were using token economies and other treatment interventions based very much on operant learning approaches. And particular services have been involved with adolescents and young people and adults with mental illness. And brain injury was really the last group to have been offered a service which was based using these approaches. And the service began at St Andrews back in 1979 with the first 16 beds in what has now become the Kemsley unit, which is quite a well-known unit, being the first to operate this sort of system of rehabilitation. 16 beds were the first number of beds that were offered, and interest in the unit was very considerable. This was the very first service of its kind ever, which had been designed for people with brain injury and neurobehavioural disability. And the neurobehavioural disability was sufficient to prevent the patients referred to the service from either reintegrating back home into the community or from progressing in their neurorehabilitation. So when we talk about people with acquired brain injury, we're obviously highlighting here their issues with neurobehavioural disability. But these are a complex group of patients, and it's inevitable that there will be other difficulties as well, be they to do with cognitive function, with their physical status, with their functional abilities, with their communication, and so on. And many of these difficulties that they present with would be amenable to rehabilitation, they would be amenable to improvement, but the presence of neurobehavioural disability, things like aggression, passivity, and so on, prevents typically those sorts of patients from succeeding in sort of more routine neurorehabilitation programs that are available. So interest in this service was considerable. There were visitors from all over the world who took an interest in this service. There was a increase in referrals, and the neurobehavioural service at St Andrews began to expand. However, Dr. Peter Eames had a vision for these services really not being based in hospital wards. After all, this was a group of patients who were not ill in a traditional sense. They were physically well recovered, and he was very much of the opinion that rehabilitation should take place in a non-hospital environment. So the tendency has been for units to open that aren't necessarily in hospital grounds. Back in 1985, Dr. Peter Eames left St Andrews and he set up Grafton Manor, which is where I'm speaking to you from now. So this was the second neurobehavioural service to open in the UK. Grafton Manor, based just about 8 miles south of Northampton in the village of Grafton Regis. It's quite a famous location. Just some historical interest here. Grafton Manor was owned at one time by the royal family. Henry VIII was a regular visitor to Grafton Manor. He visited here every summer for hunting, but also to escape the plague, which used to rampage through London, I'm led to believe, regularly at those times. And the point of interest really here is from the literature that I found on the internet. There's one account of Henry VIII coming to visit Grafton Manor back in 1528, and on the way from London up to Grafton Manor, he stayed over in Ampthill, it's not too far away, where he began, so the account tells us, to complain of pains in the head, which caused him a momentary panic. The accounts tell us that he was still feeling poorly when he moved to Grafton the next day, but here his pains disappeared. And I like to think of this as an early indicator of the future therapeutic benefits of brain injury services and Grafton Manor. So the programme became established at Grafton Manor back in 1985, and in the 90s a second unit opened in brain injury services at Ardley in Essex, Elm Park. So currently brain injury services consists of these two core services at Grafton Manor and Ardley, with a care pathway at both sites which extends into the community. So neurobehavioural rehabilitation has been around, still a relatively new form of rehabilitation, but it's been around now in excess of 30 years. And back in 1979 there was a conference held really to celebrate 30 years of neurobehavioural rehabilitation, and it was certainly recognised at that event, where many of the original as well as current practitioners got together, that since the early days of the Kemsley unit, the practice of neurobehavioural rehabilitation has spread from Northampton all over the world and has seen huge developments, and that's certainly true. What sort of characteristics does a neurobehavioural service have? Well, the first thing to say is that it's post-acute. So this is a service for people who no longer require ventilation, for example, that are past the point typically where being in a general hospital or a specialist service for people who are still very physically ill is necessary. So it's a post-acute form of rehabilitation. And it's at this stage where we see that individuals who are perhaps first exposed to neuro-rehabilitation, we see the emergence of neuro-disability, which prevents them from participating in those programs. Or indeed it could be people who are 30, 40 years down the line who are still presenting with considerable problems as a result of their injury, but who haven't received specialist rehabilitation at all up to that point. The second point to make, which I've just talked about really, is it's community or hospital based. As we just learned, it began in a hospital setting. The movement has been, though, to put neurobehavioural services back out of hospital settings and into the community. The third point to make is a psychosocial model of rehabilitation, primarily. And a very important point, which I'll be expanding on later, is that it employs a transdisciplinary team approach, where the goals that we set with our patients and residents are social or functional and are the responsibility of the entire clinical team to pursue. We'll talk about that a bit more later. And the final point here, again a very important point which we'll elaborate later in the session, is it takes place in a structured environment. A few other points. It's a data-driven approach. So neurobehavioural rehabilitation practitioners are constantly collecting information about the people who are in the program, be that about their behaviour or their functional status, their mood, whatever. It's very much a data-driven approach. This allows progress to be tracked, but also obviously flags up goals and other potential areas for intervention. This leads us to stress an objective approach to understanding behaviour, very much an approach that's based on functional analysis. So what is driving behaviour, and how can we help individuals to get greater control over their behaviour following brain injury? Okay, so the next point is who gets referred to neurobehavioural services. And again, this will be no surprise, but if we go to the literature, and we see work that was published by Roger Wood and Andrew Worthington back in 2001. Here is a list of individuals that they saw being referred to neurobehavioural services, and the obvious thing to point out there is challenging behaviour is something which typifies nearly all the groups that they mentioned. So people can be referred because they present with challenging behaviour with cognitive impairment, challenging behaviour with physical disability, challenging behaviour with both those things, cognitive impairment with physical disability, and individuals who have these sort of high-level executive disorders, but for whom neurobehavioural disability is an issue. So these are the sorts of individuals who seem reasonably intact, particularly in structured situations, but when they're in novel situations, their high-level executive disorders come to the fore as we see that they're not able to plan or organise themselves in these issues, in these situations, and that prevents them from making progress. So when we're talking about challenging behaviour in this context, what sorts of things do we mean? And here is a list. It's not an exhaustive list by any means, but there you can see for yourself the sorts of behaviours that we might see in neurobehavioural rehabilitation that require intervention, things that are preventing the person from regaining their full autonomy and fully engaging with rehabilitation and achieving their optimum rehabilitation potential, not just for behaviour but for all the other things we mentioned earlier, so their cognitive rehabilitation, physical, functional communication and so on. So many of the behaviours that we can see there are active in the sense that they're things that the person does to the environment, and we typically think of issues like aggression, for example, which we're going to talk about more in a moment, or refusals to participate in therapy. But at the other end of the extreme, as I already mentioned, you have individuals who are very difficult to motivate, who are apathetic, who have drive or arousal disorders, and that creates special issues and problems in its own right. Aggression is something, though, that we see typically is a reason for referral. So it's worth spending just a couple of minutes on looking at this issue. So the question is, how characteristic is aggressive behaviour of the sorts of people who find themselves in neurobehavioural services? And when I talk at conferences or events, I like to get people to have a think about this and to estimate how much aggression they would think would be seen in this group. So a study that was published back in 2007 by myself described the aggressive behaviour which was shown by 108 people participating in a residential neurobehavioural program over a 14-day period. So 108 people over a 14-day period, and every episode of aggression was recorded during that time. So perhaps you'd just like to think for a moment and hold in your mind what you think the estimate would be. So how many episodes of aggression do you think were seen during that time? Okay, so having thought about that, no doubt you've got an estimate in your mind. The frequency was 5,548 episodes, which often surprises people, and I wonder if that's equivalent to your own guesses. If we actually look at the recordings that were made, here we see the types of aggression, and we see that on the left-hand side there, most of the aggression was verbal, but often this is sufficient in its own right to prevent rehabilitation. But we see here, for example, on the far right-hand side, 729 physical assaults on other people. We've been asking people this question and recording their responses at events during the last year, and my experience of asking this question, and I think this data as well, confirm that even quite experienced clinicians who work in ABI tend to underestimate the amount of aggression seen. So when we ask people to guess, if they've not read the paper of course, the number of episodes, typically the mean is around 1,500, is typically what people think of, with a range from as low as 15 but to as high as 1,000. But again, most people underestimate the amount of aggression seen. So the point here is that neurobehavioural reason why patients are referred. So it's a challenging and a complex group. So now we're going to spend a few minutes thinking about how does neurobehavioural rehabilitation work. Okay, so what we see so far is we see that social handicap is a product of neurobehavioural disability. And in a neurobehavioural rehabilitation program, the main emphasis is on these 2 points here. So first of all, the acquisition or reacquisition of functional and social skills that may have been lost through brain injury. And the second point, very importantly, is the creation of an environment in which the spontaneous and adaptive performance of these skills in the context of real social behaviour is available. And this is a very important point, which again we'll see more of later. So in a neurobehavioural rehabilitation unit, the emphasis is less on formal rehabilitation sessions. It's more on rehabilitation being a 24/7 process. So whilst there may be formal rehabilitation sessions in which, for example, individuals are taught or retaught particular skills, for example, for people with difficulties with walking, it may be sitting to standing, the rehabilitation team will ensure that all opportunities where that skill can be practiced and becomes habitual are made use of. So rehabilitation is very much a 24/7 thing. What perhaps is more surprising though is how this is really sort of brought about. Learning theory is very central to this approach, not only as a means of providing rehabilitation approaches, but also in terms of understanding and managing the symptoms that we're concerned with. And I'm not going to go into a long explanation of learning theories, just to really point out one of the principles that is really core to neurobehavioural rehabilitation, the operant sort of school of learning. And most people will be familiar with this model, so again, not much point in spending too long on it. But suffice to say that behaviour will always have some form of consequence, and the model simply says that the probability of that behaviour occurring again will be influenced by its consequences. So this is a very simple model which is very well proven and which has lots and lots of application to lots and lots of clinical populations, not just ours. But it's often surprising for people to learn that operant conditioning and learning theories and learning models form the heart of a rehabilitation approach, which of course is aimed at a group in whom the very mechanisms of new learning are impaired. So people participating in these programs will typically have cognitive problems, including attention, memory, and so forth. So their ability to learn is impaired in the first place. So that seems slightly odd that a learning theory undermines rehabilitation for this group. But as we'll see, it actually has many benefits for this group. Let's talk about the structure now. Structure is extremely important in neurobehavioural rehabilitation. What do we mean by this? Really 4 levels of structure to talk about. The first is the physical environment of the place where rehabilitation is occurring. So the space needs to be sufficient for rehabilitation. It needs to be well organised. There perhaps need to be cues in the environment to help people to get orientated. The second level of structure, again essential, are of course the clinical teams who populate these sorts of services. And they typically consist of interdisciplinary teams, but also, very importantly, transdisciplinary teams. And people often ask me, what's the difference? What is a transdisciplinary team? Well, a transdisciplinary team is a team in which everyone works towards a shared set of goals and everyone contributes to the care planning in that sense. So we won't have a room where physio occurs, or we won't necessarily have a room where speech and language therapy occur in isolation. The team as a whole will address issues to do with communication and issues to do with ambulation and physical functioning. And again, it just really goes back to the point I made earlier about rehabilitation being 24/7. So a transdisciplinary team where role blurring is considerable, where everyone shares their goals, and where everyone cooperates and works towards achieving those goals is essential. And this has all sorts of benefits for people with a brain injury because it provides a very consistent approach which is essential for new learning in this group, in whom the ability to learn is impaired, as we've seen. So the sorts of teams that we see working in neurobehavioural rehabilitation, very important, possibly the most important ingredient. So teams need to be enthusiastic, driven, motivated, excellent at communicating, and at the end, when these characteristics are present, creating a very positive therapeutic climate in which people can succeed in their rehabilitation. The third element of structure is daily routine. Daily routine is extremely, extremely important. So we see, for example, we have times for eating, for washing, for getting up, for sessions. We have a timetable of activity. And this may seem quite a basic thing to talk about, but in terms of neurobehavioural rehabilitation, this creates a culture of expectations that things will happen for all. So not just for the people who are the recipients of rehabilitation, but for the transdisciplinary team and other professionals as well. And the final level of structure are the neurobehavioural interventions themselves. So these will be the sorts of individual programs that people will require to help them to succeed in their rehabilitation. So when we have all of these ingredients together, we create these structures which create a prosthetic environment, as Wood and Worthington say, within which a person's awareness and capacity for social learning are optimized. So with these structures in place, we have an ability to increase awareness in a group, and we know that as a group, this group do have problems or can have problems with things like insight and awareness. It improves motivation, and motivation could be an issue for this group, and these structures allow the team to shape behavioural responses of patients and residents into acceptable form. So again, going back to what Wood and Worthington have described back in 2001, what does this mean? This means that clinical teams deliver consistent treatment. The rehabilitation, as I've already pointed out, is not session-bound, so it's something that occurs 24/7. And through that process, new skills are acquired as habits because they're used throughout the day and reinforced throughout the day, which encourages their generalization. And the environment is rich in frequent feedback, which again is a very important characteristic of neurobehavioural rehabilitation services, and I'll talk to this point in a few slides' time. Obviously, the emphasis of people who are referred to neurobehavioural services will be in the first place in trying to change behaviour so that people can attain the autonomy that they are capable of through full participation in the rehabilitation program. And going back to our very simple operant learning theory model that we saw earlier, the processes, the principles are very simple to describe in terms of trying to reinforce appropriate, desirable behaviours wherever possible, and as far as possible trying to play down those behaviours that are not consistent with the aims of rehabilitation. So again, as we've already seen, we have this very structured environment that facilitates that reinforcement process, and we also have these individual programs that help people with their individual needs. I think there are also additional benefits to people with acquired brain injury and challenged behaviour, where we have a system of structure such that I've described. And again, it's looking mainly at why people are presenting with the difficulties that they are. So we know, for example, that some of the behavioural disorders, the neurobehavioural disorders that people present with, are driven by cognitive impairment, particularly problems with attention and particularly problems with monitoring. We often see this in people's social behaviour or in social situations. And the analogy here is our old friend Homer Simpson, who we all know loves donuts. Unfortunately, Homer is in a position of great responsibilities, we know, monitoring the nuclear power station in Springfield. And here we see perhaps an extreme example of how a monitoring program can lead to, or monitoring difficulty rather, can lead to problems. So there's Homer daydreaming of donuts, whilst all the cues in the environment are telling him, shouting out really, you need to do something because there's a meltdown that's imminent. And although that's a rather extreme example, it does describe in many ways the sorts of difficulties that we see in people with acquired brain injury, who because of their acquired brain injury have a reduced ability to monitor and attend to cues. And that can lead to behavioural deceleration, which can be seen in social behaviour, where frankly social behaviour appears odd at times because people don't pick up on cues or signals that their behaviour is appropriate or not. They can carry on having a conversation when clearly the conversation has changed, but they don't pick up on that. Perhaps they don't pick up on the fact that what they're saying is offensive to someone, and that can put them at risk. So an advantage of neurorehabilitation environments is that it does create this sort of prosthetic environment in the sense that whereas neurologically healthy people by and large are pretty good at picking up on these sorts of cues, some people with brain injury have problems. So putting feedback systems in place as part of this prosthetic environment can help because they will circumvent the reasons which drive or maintain those sorts of aspects of challenging behaviour. And this can be seen quite often when individuals are admitted to highly structured neurobehavioural programs and services, where we can see quite a quick resolution to some of the behaviours that have been a reason leading to their admission. If we look at the literature, for example, we find several case studies, or any number of case studies, where we show that giving people structured, regular feedback can lead to a decrease in the sorts of challenging behaviours that put them or others at risk. So very quickly, for example, in this episode published quite a while ago now by Zentius and his colleagues back in 1990, we see the effects of scheduled feedback on inappropriate interactions with males in a 19-year-old female patient with a severe closed head injury. And if we look at this side of the graph, we see a baseline. So we see about half of interactions this person was being appropriate. If we then look at what happens when the person is given half-hour feedback about the appropriateness of their behaviour, so there's no rewards or incentives, it's just straightforward feedback. Whilst there's some variability, we do see a considerable improvement in appropriateness of social interaction, to the point where just giving the person feedback in the evening was sufficient to raise awareness, which they didn't have before, about the appropriateness of their behaviour, so that nearly all interactions were appropriate, keeping the person safe, which of course is the main drive here. So feedback is extremely important. So these sorts of structures that we see in neurobehavioural rehabilitation sessions provide feedback which counter or circumvent problems with attention and memory, other cognitive problems which can drive behavioural programs. And we also see, for example, just building on that some people with acquired brain injury have difficulty in interpreting non-verbal cues. So again, providing much more concrete feedback can help in that respect. And again, building on that, we also see that some of the behavioural problems we see in our patients with acquired brain injury are symptomatic of the environment and are learned by way of how they've been previously managed. And I like to describe this by talking about systems of feedback. And I talk about two systems of feedback. That's the spontaneous system of feedback, that's sort of naturalistic, versus the sort of program system of feedback, which is what we see in neurobehavioural services. So very quickly, if we have a spontaneous system of feedback, so this is where interaction with patients, residents, users of these services is entirely down to individual nurses, therapists, and so on. And for individuals who are presenting with challenging behaviour, the sorts of interaction we see with staff, with carers, is inconsistent. It's often the case that people will learn to avoid these sorts of patients because understandably staff don't want to get hit or sworn at or spat at. So these sorts of systems of feedback will discourage interaction. There may be one person who is good at managing that particular individual, but these sort of programs are vulnerable because that person's not always there. And there's also a danger that people can inadvertently reward or encourage or reinforce undesirable behaviour by giving people social reinforcement. And I say that simply because in many cases we see that challenging behaviour leads to people being ignored, but when people want their needs met, they learn that by being aggressive and challenging they will get attention. So in these circumstances we see that people's appropriate social behaviour is ignored whilst their inappropriate social behaviour is responded to and reinforced. So a cardinal rule really in neurobehavioural services is to try and avoid at all times saying don't do that, well that's not good. In contrast to that, the sorts of structures that we see and the systems of feedback that we see in neurobehavioural programs through the behavioural interventions that we run, although they're obviously aimed at changing the behaviour of our patients, in the first instance they have an impact on the clinical teams. So by having feedback systems which encourage, or rather which direct staff to interact with patients at certain times, as we'll illustrate in a moment, we see a degree of consistency being introduced into the environment. We look for staff to try and say positive things about people, so it encourages positive interaction and the development of positive therapeutic relationships with people. It's less vulnerable because it's an approach that's run by the transdisciplinary team, and the emphasis is on reinforcing desirable behaviour whilst giving appropriate feedback regarding behaviour that's less desirable. So again, this slide really just makes that point. So in the neurobehavioural program, we will see a structured feedback system in place, so which helps learning, which motivation, which talks out the positive. So there may be set times during the day when feedback is given. And sometimes we will also use or couple that feedback system with systems that are based around reinforcing and incentivising behaviour. So primarily that will be about social reinforcement, telling people they're doing a great job. In some cases there may be tokens or points used as well to further help motivate individuals, whatever really will work and what the individual wants. So to illustrate that, for example, we see this sort of system operating 24/7 throughout the day. So it can happen during the structured sessions, like a group session here, where sessions will pause for feedback to be given, and in this case we see feedback being accompanied by a token being paid, and that's just to visually really sort of talk up and emphasise that feedback's being given. Similarly, the feedback will be given outside of patterns all the time. And again, this simply shows individuals making recordings following feedback to talk up the fact that these are data-rich structures. And again, this is an interesting slide because although what we see here is a patient in the middle there and a nurse on the right using a star chart, which does seem rather childish on first value, what we actually see there is something that's very positive that's happening. So the behavioural program is being used as a vehicle through which to deliver and to develop a social, positive therapeutic environment in which individuals are the recipient of praise from staff. And that can be quite contrary to their experience before coming into these structures, where their behaviour means that they're more likely to have been perhaps ignored rather than to be engaged with. And we see this becoming spontaneous, so it's not just at times when tokens or points or feedback is given. We see positive interaction with patients and users of services happening habitually. And when this happens, the rehabilitation environment actually becomes a exciting and motivating place to be in for all. So not just for the users of the service, but for the clinicians and other staff who work within that service as well. So really, just to summarise this point, we talk about behavioural interventions as being a key structure within neurobehavioural programs. Just to summarise, we use these because they change our behaviour as staff, they encourage positive interaction, and they enable a consistent team approach. And of course, all of this, as already said, helps to develop a positive social climate which promotes positive therapeutic relationships. And if we have a therapeutic climate which is positive, then this is highly predictive of good treatment outcomes. So in the last few minutes of this session, I'd just like to talk about those outcomes and talk about the evidence base for this approach. So the outcomes really are twofold in the sense that outcomes are based around single case studies of individuals and also following up groups of people, cohorts of people that have gone into neurorehabilitation programs, so we see how they were before they came into the program and how they are when they come out the other side. At a general level, a report that was compiled and published in 2010 by the Royal College of Physicians and the British Society for Rehabilitation Medicine, we see good evidence there in terms of the approach, so strong evidence regarding social behaviour and moderate evidence regarding the sort of longer term benefits. In terms of the evidence base, we can look at individual case studies. There's lots and lots of published individual case studies out there. A fairly recent review by Jorviska and colleagues back in 2007 talked this up and generally found that the case studies yielded positive findings, and the more recent review published by Roger Wood and myself back in 2011 also found this to be the case. Time doesn't permit me to describe a case in detail, but there is an example here of such work just to give you a flavour of that sort of outcome and how it's demonstrated. So a case that was described by Dr. Tony Ward and myself, published quite a long time ago now, back in 1991, concerned AB, and we can see the characteristics of AB there. She presented with lots of challenges. The most challenging, though, was her repetitive and stereotyped speech. So again, the idea is not to go here into the program and what was done. Here we do see a slide of the program action, but rather the outcomes. So the outcomes of these sorts of approaches typically will use methodologies from single case experimental design, where we have periods in which behaviours are measured over a baseline and then treatment is implemented, and we see differences between how the person is as they present without treatment and then during treatment. And there's a multiple baseline design where we have 3 baseline periods, and we can see the frequency of the behaviour here going in the direction which was down, which is what we wanted, and that's in response to different treatment phases being introduced. More importantly, in terms of outcome evidence, though, we see frequency counts of the behaviour of concern in the ward environment or the unit environment before treatment, immediately after treatment, and 3 months after treatment. So we see a decrease in the behaviour being treated, and that maintaining at least 3 months later. So this is a reasonable example of the sorts of things that we see in single cases when they're described. The other main set of outcomes, very briefly, are to do with following up cadres of patients as they go through programs, and there are quite a few studies now which demonstrate this. The first follow-up study, for example, published by Dr. Ian and Professor Wood back in 1985, followed up the first 24 patients who admitted into the chemistry unit and showed the long-term benefits of this. More importantly, from our point of view, Peter Eanes and colleagues back in 1996 followed up 55 patients, as we can see there, for quite a while after their discharge from the program here at Grafton Manor. And typical of the findings of these sorts of pieces of work, we see that as a result of being in the program, functional skills, social behaviour had improved, People were in less restrictive placements as a result of that, and quality of life had improved. And these improvements have continued after discharge. And another important point to make in terms of cost savings, this is a very recent paper published by my colleagues Mike Oddy and Sara da Silva Ramos. They followed up, or they looked at 279 people at admission to neurobehavioural services and another group at 6 months after discharge, and found, as we can see here, significant gains, again, which repeating what was found in previous studies, not only in terms of independence, but also in terms of where people were living. So most people had been living in a hospital or a residential service, but after participating in neurobehavioural rehabilitation, were discharged to the community with reduced levels of supervision. Well, the important point for commissioners of services is that the last bullet point here is that whilst neurobehavioural rehabilitation can be initially expensive, there are cost benefits per individual lifetime can be very considerable. So up to 1.13 million for those admitted within a year of injury, and the best part of £1 million for those admitted more than a year after injury. And typically services will employ a basket of outcome measures to track recovery and to demonstrate progress. So in summary, we see here a statement, again, published from 2001 by Macmillan and Oddy, who talked really of the need for the development of appropriate services for this group. And I like to think of neurobehavioural rehabilitation a bit like a blank canvas, so it provides a set of structures through which the individual's wider therapy needs can be addressed. So although the first instance may be about trying to help the person reduce neurobehavioural disability, by doing so, then other forms of therapy for other more complex needs or other complex needs can be delivered. And finally, just in this last few slides here, again, some photos taken from a paper published a while ago. But again, the point here is just to illustrate what's going on and to point out the fact that here we see an excellent quality of interaction, which is helping the individual to achieve their goals. So here we see an individual, again, there's no time to go into the detail of the program, but here we see an individual who is participating in physiotherapy. The individual previously had difficulties with emotional ability and control, for which he was given assistance. And now we're working at this point on his ability to achieve a good standing posture. And here we see a transdisciplinary approach. Here is a psychologist, here is a nurse, and behind the camera, obviously you can't see him as a physiotherapist. And the individual is engaging in a task there, at the end of which he is given reinforcement. And the point to mention here is the look of absolute pleasure and delight that he's got on his face there. He's very motivated to achieve, and these sorts of structures help motivate and help patients to achieve their goals, which in his case was to improve his walking, which he achieved. So in the last few seconds here, what's the minimum for these things? What's the minimum required to make neurobehavioural rehabilitation work? Just to sum up what I've said. It's absolutely essential that we have a system of expectations within a unit to set the social and the rehabilitation context. So some basic rules about everyday life are essential. We need a timetable of activity throughout the day. We need a system for helping individuals to learn by giving them feedback, and perhaps systems to help reinforce, and definitely systems to record their behaviour. We need a basket of outcome measures to track their progress. And we need training programs to underpin their skills. So what I've talked about today is an introduction to neurobehavioural rehabilitation. If you visit the website, again, you can just Google this, put into ACNR into Google, it will take you to the website of the journal Advances in Clinical Neuroscience and Rehabilitation. And on the front page there, you'll see what I'm pointing at here. Hopefully you can see that, a link. And if you follow that link, it'll take you to the Partnerships in Care website and will list for you the other seminars in this free educational program. So our next session is being given by my colleagues Laura Murphy and Sean O'Gara, and that will be in April. And they're going to be talking more in detail about the sorts of things that I've outlined today. So the title of their session is The Rehabilitation Process at Grafton Manor, talking about baselines, talking about outcome measures, and talking about treatment pathways. And if you'd like to be involved in that seminar, you can log on there, and future seminars, you can also log on for those too. Here's my email address. Thanks for listening. If you have any questions you'd like to ask me, then perhaps just take a minute to take my email address down and let me know. I hope you've enjoyed this session, and I thank you very much for listening today. Goodbye.